All right, let's plan to go ahead and get started. If you're ready, Dr. Mehta. Uh, we are really excited to have Dr. Mehta joining us here today, one of our incredible ID faculty who was trained here, and I had distinct opportunity and pleasure working with her July for intern year. And what a joy it is to watch how far she's come and to be able to watch her present with us today. She is an assistant professor of medicine in the infectious disease division here at Emory. She received her undergraduate degree at the University of Texas at Austin, her MD at UT Southwestern, and then came to Emory for internal medicine and an IB training. Starting in residency, she began working with Dr. Colleen Kraft on her work on microbiome therapies for C. diff and other infectious diseases. In fellowship, she evaluated outcomes for all fecal microbiota transplantation for her master's in clinical research thesis and was involved in post-marketing studies for novel microbiome therapies for C. diff. She's now building a clinical practice specializing in microbiome therapies for C. diff and conducting clinical research on gut microbiome dynamics in patients with infectious diseases. Thank you for being here, Dr. Mehta.
Thanks. Let me just share my screen here. Hopefully that looks correct. Someone stop me if it doesn't. But thank you so much, Dr. Masser. I'm so happy to be here with everyone today. And I am going to be talking about what is new in Clostridioides difficile management. I'm going to go over some changes that have happened, some new therapies that have come on board, and also just go over some of the data for some of the guidelines that we already have. As this audience likely knows, the brief when we give grand rounds is to talk about something personal or kind of our journey to end up where we are. And I just wanted to share a little bit of that with you all. So as Dr. Masser mentioned, I'm fairly early faculty. I don't have a lot of wisdom to give or anything, but I can kind of tell you how I wound up as the gut microbiome C. diff girl. So I became interested in ID pretty early on. At some point my sophomore year of college, I panicked and realized I didn't have a bio class and kind of slotted in the only thing that was available, which was a microbiology course, which I immediately fell in love with and, went into medical school interested in ID, had done a lot of tuberculosis work up until that point and thought I was going to be a TB person. But one of my best friends from college was a PhD immunologist working out of a GI lab up in Boston. And she was telling me about all of the cool work that she was doing. And so I started to look into this whole gut microbiome question and concept. And when I got to Emory, very early on, my APD, Dan Dressler, asked me what I wanted to be when I grew up. And I said, kind of interested in looking at the gut microbiome. Does anybody do that around here? And he directed me to Colleen Kraft, and that was kind of the beginning of a really amazing mentor-mentee relationship. And I think since then I've been able to work with them and look at kind of the clinical aspects of the gut microbiome and how we can kind of weaponize it in our favor, which is a super cool thing to be able to do. And I think we're in a really cool space as we're just starting to kind of unravel a lot of the potential of the gut microbiome. And so I have patients that also ask me, like, why do you do C. diff? And I think it's because it's kind of the most concrete example that we have of how we can manipulate the microbiome to really serve us. And that's a really, really cool thing. And I think it's kind of the entryway into a lot of really interesting things. And so when I joined on faculty, I kind of am taking up the mantle of kind of being the clinical arm of our group. And that's been a really fun and exciting adventure. So come talk to me if you're interested in any of that. So no conflicts of interest. And I'm just going to get into my outline here. We're going to talk a little bit about antibiotic management of CDI, just kind of the basics, go through the guidelines and talk about why we recommend what we recommend. We're going to talk about microbiome therapeutics for CDI, which is what I'm very excited about, and then a few novel therapies in the pipeline. Learning objectives for this talk are to learn a little bit more about the role of the gut microbiome in C. diff pathogenesis, what are the new available therapies for C. diff, and how patients can gain access to those therapies here at Emory. As is tradition, we will start with a case. So this is a 62-year-old female with a history of COPD and lupus, complicated by lupus nephritis on azathioprine and prednisone, who presents to our outpatient infectious diseases clinic with recurrent diarrhea. And all good doctors, but especially ID doctors, are really obsessed with a good history. And so let's look at what this patient's been up to. So about 12 weeks ago, so about 3 months back, she received some ciprofloxacin for a UTI, developed some diarrhea, and was diagnosed with her first episode of life of Clostridioides difficile infection, which is going to be the acronym I use frequently throughout this talk, CDI, Clostridioides difficile infection. And then about a week later, she completes her initial course of vancomycin. Then unfortunately, she gets re-hospitalized with a COPD exacerbation. And once again, during that hospitalization, develops diarrhea, and is again diagnosed with CDI. At this point, she's given a course of fidaxomicin, but unfortunately, she just came into clinic with another episode of diarrhea, and we once again suspect that she has recurrent CDI. And so I think the main question in this talk is, what do you do next in these cases? Just to make sure that we're all on the same page, I just wanted to go over a little bit of an intro to C. diff. So what is C. diff infection? It is the most common healthcare-associated infection in the United States. It is caused by a spore-forming gram-positive anaerobe, causes significant diarrhea, but it also can cause abdominal pain, nausea, vomiting, and in severe cases, ileus and toxic megacolon. It's been labeled an urgent threat by the CDC, and nearly 500,000 cases are reported per year in the United States. So as I mentioned, I'm particularly interested in recurrent CDI, and what do we know about rates of recurrent CDI? So if you're sitting at episode 1, you have about a 25% chance of having another episode. Once you're at episode 2, that chance increases to 30 to 35% chance. And by the time you're at episode 3, you start out at about 40%, and with each subsequent episode, make your way up to about 50% rate of recurrence. So that's kind of interesting, right? Having potentially like a pneumonia doesn't necessarily directly set you up for another pneumonia, but C. diff is special in that way. And our hypothesis as to why this happens has to do with how C. diff works in of itself. So I think most of this group is probably pretty familiar with this paradigm of patients get exposed to antibiotics. That leads to dysbiosis, or sort of an imbalance of the traditional commensal bacteria in the gut, which sets up a host for susceptibility to C. diff infection. Now, when the C. diff infection actually occurs, the toxins disrupt the epithelium, and that disrupted epithelium is a rife place for further dysbiosis to occur, because it's not as hospitable to many of the bacteria that are used to living on a healthy epithelium. And then what do? We treat these patients with antibiotics, oftentimes something like vancomycin. And I think that we are very familiar with the paradigm that systemic antibiotics, your fluoroquinolones, your clindamycin, are increasing risk for C. diff infection. But I think what is less appreciated oftentimes is that antibiotics such as vancomycin itself also can damage the gut microbiome, as it's not particularly precise. Vancomycin is a pretty broad spectrum antibiotic. And so now you have a disruptive epithelium, and then treatment with an antibiotic that not only tamp down the C. diff, but potentially some of the other organisms. And that does set you up for having a bit more of a fragile gut microbiome than you did when you started. And so it takes a little bit less of an insult to drive a patient back into another C. diff infection. And I think that's at a 10,000-foot view, kind of one of the mechanisms by which each episode of C. diff sort of portends the next. So who's been getting recurrent C. diff? So this is some work that I did for my master's in clinical research. The actual research ended up being looking at fecal microbiota transplantation use in the Atlanta metro area, but some of the initial work that we were doing is just sort of looking and characterizing recurrent CDI in the Atlanta metro area. So this is using emerging infections program data, which sort of pools all of the C. diff diagnoses in the metro Atlanta area, which totaled over 13,000 cases in total and over 3,000 cases of recurrent CDI. And I think the finding here are particularly important because as we move forward, I'm going to talk about patients that we consider to be high risk for recurrence. And I think that oftentimes we think about our very immunocompromised patients, maybe patients with IBD. And I think that the risk factors that we actually see in real life are worth considering as well. So in our cohort, by far and away, one of the largest risk factors for recurrent CDI was patients on dialysis. And I don't know that we always think about dialysis as being one of our top risk factors for CDI. Of course, readmission within 90 days of a CDI episode will set you up for recurrence. Just general renal disease outside of dialysis, so this is your CKD patient, also has elevated risk of CDI in our cohort. And then a lot of other chronic diseases were also found to be statistically significant. So CHF, COPD, diabetes with complications, as well as liver disease. And I think this is a lot of this is a surrogate for sort of touches with the healthcare system, as well as some immune dysfunction that probably also exacerbates patients' risk for recurrent CDI. But this is the population in addition to our immunocompromised folks that I want you to keep in mind. The immunocompromised folks, just our N wasn't quite large enough, so they didn't show up in this cohort, but they certainly are at high risk of recurrence as well. Before we get into microbiome therapeutics, let's just make sure that we're kind of on the same page about therapy for C. diff infection and just kind of go over really quickly the 2021 focused update on C. diff infection. With particular interest, I think, in fidaxomicin, because I think that was the headline when this guideline first came out, is that now, even for the initial episode of CDI, the preference is fidaxomicin over vancomycin, whereas in the prior data, it was sort of can consider and a little bit more equivocal about that recommendation. But then in the most recent IDSA guidelines, they recommend fidaxomicin as the initial therapy, and wanted to talk about where that kind of came from. So after an initial episode, you want to use fidaxomicin, alternatively vancomycin. After somebody's had a first recurrence, we're reaching for fidaxomicin probably a little bit more definitively. You want to use 10 days, and then in patients who have received fidaxomicin times 10 days recently and now are coming back with a recurrence, I think there's a little bit of data to show that this more extended course of every other day for 20 days might be a better option for those patients. When these guidelines came out, and actually up until a couple of months ago, this is actually where we were also using bezotoxumab, and we're going to talk a little bit about the fate of that particular drug shortly. And then amongst patients with a second or subsequent recurrence, again, we're reaching for fidaxomicin, we're considering a vancomycin taper, and then this is where our FMT and bezotoxumab were also being recommended. And those things have now changed a little bit, and we're going to talk about that moving forward. But let's talk a little bit about fidaxomicin. It's sort of a first-in-class macrocyclic antibiotic, very minimally absorbed by the GI tract, works specifically on RNA polymerase and is quite specific to gram-positive spore-forming anaerobes. And I think this is really where you see the superiority over vancomycin, in that it is a much more precise antibiotic that's going to target the C. diff, but much less the other organisms in the gut. So where is this recommendation for fidaxomicin after an initial episode coming from? So it's based on 4 randomized control trials, which included about 1,700 patients. And they were specifically looking at vancomycin versus fidaxomicin for an initial episode. And one thing that I wanted to emphasize is that there was not a difference in clinical cure. So they didn't actually see much difference in the outcomes of that episode that you were treating. Really, where you got the benefit is in recurrence rates. So at 4 weeks, the vancomycin group had higher rates of recurrence compared to the fidaxomicin group. Now, the effect size is arguably not massive, right? Look at that risk ratio and how close that confidence interval gets to 1, right? Unarguably statistically significant, and that is where this recommendation is coming from. But I think that when you're looking at it, the cost differential for a 10-day course is about $2,500 versus $30. And so I think that looking at this, Emory and a lot of other health systems sort of said, okay, we appreciate that the recommendation is for everyone at initial episode to get fidaxomicin, but I wonder if we can be a little bit more nuanced and sort of look at this therapy in a more nuanced manner. And I think some of the subgroup analyses also demonstrated that patients at higher risk of recurrence really benefited much more from fidaxomicin, the patients that were more likely to go on to have recurrence anyways, compared to more healthy cohorts. So how are we using fidaxomicin at Emory? This is also me using this opportunity to plug our uCentral app and guidelines associated with that. So for those of you who maybe don't have this app yet, would recommend getting it. It's the uCentral app, and you can get some Emory Healthcare antibiotics, antimicrobial stewardship information on there. We specifically have treatment guidelines for a variety of different infectious diseases. We also have, penicillin allergy and all these other things that you can see there on the left. But specifically, I'm going to highlight our CDI guidelines, which we wrote not even a year ago, and have already are already going to need to change, but the fidaxomicin information stands. So here's our indications for fidaxomicin in the Emory system. So this is anyone with a recurrence, and then first episode of CDI with 2 or more risk factors for recurrence. And so this is patients over the age of 65, meeting criteria for what we used to call severe infection, so WBC greater than 15K, or a serum creatinine that would qualify you as a AKI. Patients who are receiving concomitant antibiotics that are clinically indicated, patients who are immunocompromised, and then based on our EIP data, we also included chronic kidney disease and dialysis patients. So that's kind of what we're going to do with the fidaxomicin. I'm going to make a brief aside about vancomycin prophylaxis. I get asked about this quite frequently, and it turns out that it's more complicated than we initially thought, or than I think a lot of people think it is. And my inspiration for this particular slide came from a really great talk from Eric Duberke, who is huge in the field out of WashU, and he came and spoke with our transplant group and sort of said we shouldn't be using vancomycin prophylaxis in patients who are on systemic antibiotics and have a history of recurrent CDI. And I think it's nuanced. I think there are some cases where you can use it, but I think maybe we need to be less liberal with it than we used to be. Just to be clear these are patients who have a history of CDI and are now being treated for another infection. They have a UTI, they have pneumonia. They're going to require antibiotics, and our practice is to give potentially a low dose of vancomycin to those folks for a little bit longer than their duration of therapy to try to tamp down or prevent C. diff infection in the setting of their antibiotic course. So, most studies do demonstrate some prevention of RCDI during the course of vancomycin. Subgroup analyses show that that is probably more relevant in more immunocompromised folks, or patients at high risk of recurrence, as defined in prior slides. There is also good efficacy in primary prevention. There are some studies on stem cell transplant wards and things like that, looking at prophylactically giving vancomycin to patients who are colonized and plan to be on a lot of antibiotics, which actually do show some pretty good outcomes for that particular group. And honestly, it's the best thing that I have for our patients who are not eligible for microbiome restoration and usually cannot get funded for lifelong fidaxomicin. But the cons are certainly there. And I think a lot of the cons are thought about by the people who look at this data and look at this kind of with regard to the role of vancomycin in the gut microbiome. So there have been a lot of animal studies and some human studies as well that demonstrate that vancomycin leads to sustained gut dysbiosis, similar to third-generation cephalosporins. So the argument that Dr. Duberky was making is now you're sort of giving them two hits. You're giving them whatever systemic antibiotic they needed, plus the vancomycin. And by the time they kind of emerge out of this, their gut microbiome has kind of been decimated from multiple angles. It is correct that there are no RCTs that demonstrate efficacy here, and the studies that do demonstrate efficacy are kind of lower quality, a lot of observational trials, a lot of heterogeneity amongst dosing, amongst the patient groups, things of that nature. And the argument that Dr. Duberky and many others make is that the follow-up time in a lot of these studies is not super long. And so the question is, do they sort of have almost like not a rebound, but do they have recurrent CDI? Are you just sort of staving it off and stopping it from happening then? But inevitably will happen later because now you've sort of damaged the gut microbiome. So this is very confusing. I think based on our current data, and I would also point out that it is actually in the guidelines. So if you look at the ACG guidelines, which came out earlier in 2024, there certainly is a section about vancomycin prophylaxis, and with a lot of asterisks and caveats, it is a recommendation. So here's, I think, what we do about this conflicting data. I think if you have a patient that has had a single episode of CDI and is healthy otherwise, I don't think that's the patient that you're going to use vancomycin in. If you've got a really medically fragile patient with a bunch of episodes of CDI, I think that's still the patient that you're going to use it in, because I think the argument is made that another episode of CDI might be quite detrimental to their health. And then I think in patients who have had multiple episodes of CDI but are not quite as medically fragile, this is really where the gray area comes in. And I think that this is going to be a sort of shared decision making between yourself and the patient. The way that I typically give it, once daily is actually enough. You get very high concentrations in the gut. So vancomycin 125 daily, continued for 5 to 7 days past the course of systemic antibiotics. The caveat that I'm going to give you that I really want everyone to hear is that if we're restoring the gut microbiome, we're using what we now have instead of FMT to give back a lot of good bacteria. Let's not give vancomycin after that, because what you're probably doing is killing the good bacteria that we just restored more so than anything else. And so I haven't been recommending vancomycin in those cases outside of some very specific circumstances. And I try to be really mindful about how I notate that when I write my notes. So C. diff beyond the antibiotics. This is the fun stuff, right? So pathophysiology of C. diff infection, allow me to get nerdy just for a couple of slides, and then we'll get back into the clinical information. But I think it's important to understand why this works, because I think it helps us think about what interventions we should be doing next, right? So life cycle of C. diff is you're going to ingest the spore. It will go into the gut, and it will the process of germination allows the seed of spore to transform into vegetative state, which is where it replicates. And the trigger, or one of the major signals to drive germination, are primary bile acids. And these are bile acids are produced in the liver. And one of the roles of the gut microbiome is to hydrolyze those bile acids into secondary bile acids. And this is such a strong signal that people who study novel C. diff therapeutics actually use bile acid concentration to prove that the gut microbiome has been restored to appropriate function. And the reason that this is important is it just sort of demonstrates the importance of a functioning gut versus a non-functioning microbiome in allowing these primary bile acids to go unhydrolyzed and drive this germination process, which is sort of the first step in setting yourself up for C. diff infection. There are a lot of other metabolites made by the gut microbiome. Short chain fatty acids are becoming particularly interesting to a lot of people who study this. I think a lot of people forget about the gut virome. I think we talk a lot about the microbiome. There is a mycobiome as well as a virome, and there are bacteriophages which play a role here. And then bacteria also make a bunch of antimicrobial peptides. And so you can imagine, as we're wiping out a lot of these functions, that's really opening up the door for C. diff to come in and get very cozy in the gut. And so a susceptible host will undergo what we call colonization, and patients with a robust microbiome will have what we call colonization resistance. There are some other signals that trigger toxin production, and that is sort of what sets you up for this sort of cycle of recurrent C. diff infections, right? And then, as I mentioned, the epithelial damage sort of sets you up for future infections as well. So the concept of replacing the gut microbiome to do all of these really useful functions is not new. So the very first written account of this, of using fecal matter to treat a diarrheal infection, was back in 400 AD, found in a Chinese handbook of emergency medicine. Couple millennia later, we have the first report of FMT used for an entity called pseudomembranous colitis. We did not know what was causing that, but this was a case series of about 4 patients, all of whom did quite well after receiving FMT. About 20 years later, we actually learned that this pseudomembranous colitis is caused by Clostridium difficile bacteria. And then the microbiome therapeutic space really started to speed up in 2013 when we get our first randomized control trial by Ben Nude et al. Published in the New England Journal of Medicine comparing FMT to vancomycin for RCDI. And that's really what sets us up to use this eventually as like a standard of care. The FDA approves the use of FMT without an IND about 6 months later. And then about 3 years later, we have bezlotuximab, which is a monoclonal antibody against toxin B that's FDA approved. This is also another therapeutic that's been found to decrease rates of recurrence after concomitant antibiotics. And then in 2018, FMT is recommended in the IDSA guidelines. And then everything sort of comes to a screeching halt, as did the world in 2020. So SARS-CoV-2 is detected in stool, and the largest biobank sort of halts the production of or the shipment of material for FMTs. So these are fecal transplants that are done to replace the gut microbiome. For those of you who may not be familiar, how we were historically doing fecal microbiota transplantation at this institution and most others is we were getting material from donors through Open Biome, which was in a biobank. They were shipping it to us, and then our GI colleagues were placing the material via colonoscopy, and that was sort of how we were doing FMTs, and we did many of them over this period of time. All of that sort of came to a halt in 2020. But then that sort of created an interesting scenario where simultaneously to that, the FDA approves two novel biotherapeutics. So live JSLM is an enema product that the FDA approved in December of 22. And then on the heels of that, a few months later, the FDA approves live BRPK. Now, I know that we're not supposed to be using brand names very commonly in grand rounds. However, both of these names are incredibly confusing, and so you will hopefully excuse me for referring to these in both capacities. So here are our currently approved therapeutics for prevention of RCDI. So these are all to be used as what I consider to be a chaser. So you complete your course of antibiotics and then receive one of these therapies. So fecal microbiota transplantation was sort of the original. It is, as I mentioned, usually given via colonoscopy. Fecal matter is implanted, deep in the gut, and that's how we were historically doing that. Rebiota live JSLM is an enema product that's basically cryopreserved human stool. And it's sort of, basically it's an FDA-approved FMT with maybe a little bit less volume than we historically were giving, but it's given via enema, not colonoscopy. VOWST live BRPK is an oral product. This I consider to be a probiotic that works. It's spores derived from healthy donors, of firmicute spores derived from healthy donors that are used to treat C. diff, to prevent recurrence of C. diff and replant the gut microbiome. And then bezotuximab is a monoclonal antibody against toxin B. However, since being asked to give this talk, few things have changed. So Open Biome stopped distributing FMT at the end of 2024. And then about a month later, Merck stopped distributing bezotuximab, which is really frustrating. Open Biome's issues had something to do with an IND, but Merck hasn't given a rationale for their stopping of distribution of this, but we now have just a few doses left here at Emory, and we have no date of getting any more at this point in time. So now what do we have left? We have Rebiota and VOWST left at this point. So let's learn how to use what we have left. So looking at the guidelines, very helpfully, ACG-AGA in 2024 released these guidelines for the use of what they call fecal microbiota-based therapies. They recommend use after second recurrence, so this is after episode 3, or in high-risk patients who have just had 1 to 2 episodes. One thing that they put in the guidelines, if you ever read them, that we're going to do a little bit differently here at Emory, they recommend the use of traditional, conventional fecal microbiota transplantation in mildly or moderately immunocompromised adults. However, given A, we don't have access to traditional FMT material, and B, we here at Emory have had pretty good luck giving it to immunocompromised folks. We're going to do that a little bit differently. So just kind of an introduction to live biotherapeutics. So the purpose here is to prevent recurrence, not for clinical cure. So this is something that we're going to give at the end of our antibiotic course where the diarrhea has already resolved, to replant the gut microbiome and sort of undo some of the damage that the toxins have done on the epithelium and whatever the inciting insult was that led to the dysbiosis in the first place. So one key thing that I want everyone to know is that these microbiome therapeutics were studied at the end of standard of care therapy. So the patient needs to be continued on their vancomycin, fidaxomicin, until they're able to get these therapies. And sometimes that means extending their course of antibiotics for a little bit longer while we sort out the logistics. The patients typically stop their antibiotics about 48 hours prior to planned LBP. And then take their LBP, and then that's kind of the end of it. Whether that is an oral product like live BRBK or an enema product like live JSLM. If planned for either, I think this is something that comes up quite frequently. There's likely little benefit in spending the money on fidaxomicin compared to vancomycin if we're going to be replanting the whole gut microbiome anyway. So if this is a patient that, looks like is probably going to end up getting Vowst or Rebiota, then perhaps there's very little benefit in spending that extra money because ultimately the difference between these two things are damage to the gut microbiome. So if we're planning on repairing it, perhaps you're not getting that much bang for your buck here. And the other thing to consider is oftentimes patients who are planned to get these therapies are going to need an extended course because you have to get into clinic to see usually me, and then it takes about 10 days for the drug to get, in the case of Vowst, mailed to the patient, or in the case of Rebiota, mailed to the clinic to actually administer it. And so that's just something I wanted to kind of plant in people's conscience there. So learn a little bit more about these therapies. So a primer for live JSLM, previously known as RBX 2660. Brand name is Rebiota. It's produced by Ferring Pharmaceuticals. And this is cryopreserved stool. They have very, very, very carefully screened some donors, and the donors make a contribution, and that is cryopreserved and then mailed out to clinics and potentially individuals. Quality control wise, they screen the fecal material for pathogens, but also maintain a baseline level of diversity. And they want there to be a certain level of colony-forming units of Bacteroides, important commensal taxa. It's administered 2 to 3 days after the end of antibiotics and delivered as a single dose enema. This can be done in the clinic, and they also have a Rebiota at home option, which you have to have a payer that's willing to fund. But that's something that a lot of patients have had some success with as well. Data for what was previously RBX 2660, now live JSLM. They, just looking at the phase 3, they were looking at patients who have had 2 episodes in 8 weeks or 2 severe episodes requiring hospitalization in the past year. I think what's important to note here is the exclusion criteria. So they didn't take patients who had refractory CDI. So your patients who are still having diarrhea, that is not the patient for whom this was studied. These are, they were taking patients who had had several episodes of CDI, but at the time of receiving the therapy, their diarrhea was gone. They excluded patients who had recently gotten besletoxumab or an FMT. And then this group, I think, has a very big Venn diagram with our C. diff population here at Emory, right? Patients with chronic diarrhea, IBD, IBS, colonoscopy, short gut syndrome, and immunocompromised were all excluded. So we don't know how these therapies necessarily work in a lot of these populations. And their primary endpoint was an absence of CDI-related diarrhea at 8 weeks. The study was marred a little bit by COVID-related issues, and so they did some Bayesian analysis and included some phase 2 data, thus the asterisk. But ultimately, what you see here is looking at the modified intention to treat. 70% of patients at that 8-week mark remained CDI-free compared to 58.1% of patients from the placebo arm. They had pretty sustained response. So if you responded at 8 weeks, most likely 6 months out, you still did not have a CDI episode, which is really great for our patients. And looking at the adverse event rates, the study drug had a slightly higher adverse event rate, but the vast majority of those were constipation, diarrhea, abdominal pain, bloating, things like that, that honestly would be probably expected as the gut microbiome sort of recalibrates. There were no serious adverse effects related to the drug. Live BRPK, previously known as Series 109, brand name Voust, which is produced by Series Therapeutics, which was acquired by Nestle. Yep, those Nestle have their little arms and lots of different things. And so this is live purified firmicute spores. These are spores that are obtained from healthy donors and then undergo a proprietary ethanol purification process, remove everything else, and this is sort of encapsulated into capsules which are sent out to patients. Again, administered 2 to 3 days after standard of care antibiotics. Requires a laxative prior to administration. The concept here is to sort of wash out any residual vancomycin that still might be in the gut, and create sort of a nice clean plane for engraftment of the bacteria. Sort of a similar trial setup. Couple of nuances is that instead of 2 episodes of CDI, they wanted greater than 3 episodes within 12 months. Exclusion criteria that I highlight here was virtually identical. Again, we don't know how this worked in the IBD, IBS, colostomy, short gut group. But their results were also very good. So 88% sustained clinical response at the 8-week mark compared to 60 in the placebo group. Very, very similar adverse event rates and no significant adverse events related to the drug were reported. So hopefully, many of you are thinking, this sounds really good. And how do we get this at Emory? Send them to us. So this is the infectious diseases clinic here at Emory Midtown. And we have sort of carved out a few slots a week for refractory or recurrent CDI patients. They're usually seen by me. They're seen at the MOT 7th floor ID clinic. So to be eligible to see me in clinic, we want 2 episodes of CDI in the past 365 days or 3 lifetime episodes of CDI. I'm very happy to see anyone who's been struggling with recurrent CDI, but bonus points if they're actively on therapy and they come in sort of very soon after their most recent diagnosis, because that's the patient population in whom I can give Voust, Rebiota, and replant their gut microbiome and sort of break that cycle. So we offer CDI counseling and just sort of general advice about prevention and protection against recurrence. We give Voust and Rebiota in office or at home, and then we also have a few research projects, something as simple as send in your stool and we will analyze it before and after you get Voust and just sort of see in a real world population what happens, all the way to a phase 3 clinical trial that I am site PI for that I'll talk to you guys about in a moment. So information about how to refer is right here. You can either epic message me or email me, or reach out to the MOT 7th floor ID admin team. They know to route the RCDI patients to me. I've been usually able to get them in within about 2 weeks of the referral. So my request is if the patient is on anti-CDI therapy at the time of referral, please extend the antibiotics until they come see me, and then we can decide if they're eligible for, or if they choose to take one of the LVPs. I will write the script to continue it on until they get the therapy in their hands. Few practical considerations or just kind of questions, FAQs that people may have with regard to these therapeutics. So live BRPK VOWST is mailed to patient homes with a laxative in the packaging. It's a very straightforward experience for the patient, and they will continue their antimicrobials, and the day that it gets delivered, I usually tell them stop and then sort of come up with a calendar of how they're going to take it. Live JSLM rebiota, if it's going to happen in clinic, requires a second clinic visit because we have to decide on it and then order it. And the patient needs to sort of be reliable enough to come back, because once we order it, there's a very short half-life before it thaws and is no longer useful. We can set up rebiota at home, but that is payer dependent. The cost differential comes up sometimes. So live BRPK, the oral VOWST is $20,000 for a course. Live JSLM is $9,000. But patient assistance has been very good for both. I haven't had it be cost prohibitive for anyone yet. And so it is worth noting that that may change. But right now we're really enjoying this honeymoon period. As I've mentioned a few times, the diarrhea should be resolved. Vancomycin is fine if they come in on that. And I think one of the few things that makes me not want to give these therapeutics are if patients are planned to be on long-term systemic antibiotics. So your patient who has a history of a prosthetic joint infection that's on lifelong suppressive antibiotics, or has endocarditis or something like that that's going to require a prolonged course of antibiotics, because you're engrafting bacteria that might end up just getting killed quickly by the systemic antibiotics. That's a patient in whom perhaps you're considering something like a long-term vancomycin, but we'll consider those kind of on a case-by-case basis. Talking a little bit about VOWST at Emory. So this is what I've done at Emory ID. I know our GI colleagues have also given a little bit of VOWST and rebiota as well. So we have given, I've been doing this for a little under a year now. We've had 19 patients receive VOWST, about 50-50 gender split. Median age is 68. I have given VOWST to a 90-year-old who did quite well. Patients have a pretty high burden of CDI. A lot of these patients have up to 5 episodes. Almost half of them have had 5 lifetime episodes or more of CDI. And so that's kind of worth noting that, these are patients that have been really dealing with this for a while, and we're still seeing pretty good rates of success, at least so far. Over half of them have renal disease. And I've been giving it to a lot of patients who are immunocompromised. 3 of our patients have been active WinChip patients who have received VOWST along with their chemotherapy. And our recurrence rate is about 20% at this point. And each of these cases was a little bit different. 2 of these patients got a redosing of the VOWST and did very well after that. And the other 2 patients so far are doing okay. So that's kind of been our success rate. But in a patient population in which their almost average rate of CDI episodes is greater than 5, it's a pretty good outcome, I would say. And so I've been really pleased with this therapy. So just a little plug for one of our studies. So just last week, they moved on to stage two. And that is what I'm particularly excited to share with you guys. But we're looking at an oral therapeutic, which is a consortia of multiple strains of bacteria. VOUST is just vermicute spores. This is a little bit more of a precisely engineered combination that's not derived from human stool, but rather sort of eh, derived in a more replicatable manner. Um, so what's really cool about this is, in addition to having had two episodes in the past 6 months, patients are also eligible if they're having their very first episode, but they're over 75 years of age, or if they're sort of in our higher risk group, right? So your CKD patients, regular PPI use, you've had an episode of CDI maybe greater than 6 months ago, but you also are over the age of 65, or if you're immunocompromised. And so if you come across those patients, inpatient, outpatient, do let us know. We're really interested in seeing these patients, because I think that this is sort of the next frontier of sort of stopping the C. diff before it sort of gets away from us, and trying to restore the microbiome after episode one. So super excited about that. And do let us know if you have anyone in mind for that. Few additional therapies on the horizon. Ridinazole is a precision antibiotic that binds this DNA minor groove. The exact rest of the mechanism isn't totally known, but it seems to have, at least in the studies, look sort of similar to fidaxomicin in that cure rates are not particularly different, but rates of recurrence compared to vancomycin are lower in the study drug group, and there's less disruption of the microbiome as measured by bile acids and diversity data. It hasn't yet been compared to fidaxomicin, but is something that is worth taking a look at. It's completed phase 3 and might be something that comes out onto the market as like a competitor to fidaxomicin, which would be interesting. And then the CDI vaccine work has been going on for a long time. The Cloverl trial made phase 4 last year. And while it did not meet its primary endpoint of CDI prevention, there were shorter durations of symptoms and need for medical attention. So perhaps there's some promise there as well in looking at using vaccination against our particularly high-risk individuals. So more to come on that as well. And with that, I will say thank you. This is my soon-to-be 18-month-old on a recent vacation, and acknowledge Dr. Kraft, Dr. Fritkin, for helping me in a lot of the research that I presented today, and then our ID clinic team that makes it happen. Specifically, Leah Ray is our incredible LPN who helps us make all the paperwork happen that gets our patients VOUSed, and couldn't do it without her. So, and then very thankful for the group that helped write the CDI guidelines as well. With that, I will take questions.
Thank you, Dr. Mehta, for that really excellent presentation. I really appreciated so many of your very specific updates, as well as information about the shortages, or not shortages, but just sort of lack of certain medications going forward, given what a common challenge this is for many of us. I'm not surprised to see a decent turnout from hospital medicine, because I know it's something that we certainly struggle with for our hospitalized patients. What questions do we have in the chat?
Looks like none so far. Yes. So um, Quick plug reminder that we have a penicillin delabeling protocol. That is a very good point. It is in the same place as some of the other things that I showed you on the UCentral app, and it is something that is definitely worth doing so we prevent um, overuse of antibiotics. Okay, Marcus. What's your approach to persistent diarrhea and non-resolving C. diff? So great question, Marcos, because I used to send them all to Dr. Ed Levert, who is doing FMT, and that has changed now. I think what we're going to need to do, honestly, is probably start considering Rebiota in those folks, considering that Rebiota is basically FDA-approved FMT. There's been an argument that the CFUs in Rebiota is a little bit less than it was for traditional FMT, but honestly, FMT used to be so heterogeneous. I don't know. So I think that that's what I would do in those patients. At this point, I think that replacing the whole gut microbiome rather than just the firmicute spores is probably what you're going to need to do in those patients. Oh, thanks, Anandi. Yes, thank you for asking about donors. So yes, they have really strict criteria. The joke used to be that it was easier to get into Harvard than to be a stool donor. So they have very strict criteria when it comes to comorbid conditions, everything from BMI to what medications that you're on, recent travel, etc. So they are very, very, very specific. I don't have it in this presentation, but I've made slides on donor criteria before, and they are quite stringent. Oh, thanks, Susan. So there are Grady guidelines that I actually now am realizing I haven't looked at in a minute either. So I will certainly be doing that as well.
Any other questions?
For those of you who are Grady-based, they are trying to, Dr. Sheena Kandaya and Dr. Tanvidir are doing Rebiota and VOWST there. But if you have a patient that you want to send my way, please do as well. So either way works fine.
And a quick reminder for folks, in order to obtain your CME, please do complete an evaluation for today's session, and you can access that both through the QR code that is up on the screen now, if you can scan that, and Kim McMillan will also be sending out the link in the email that comes out after Grand Rounds. All right. It looks like Dr. Mehta has answered all of our questions about C. diff, and certainly, as Dr. Manning said, given us something to sort of ruminate on and reflect on. All right. Well, thanks everyone for being here. Have a great rest of your afternoon, and we will see you later this month. All right. Bye, y'all.